Well, hi, everyone. I'm Dr. Carolyn Majcher, an associate professor and the director of residency programs at the Oklahoma College of Optometry. The first case was so insightful, and I'm very excited and honored to be able to guide you here through a few more cases. So this next case is an 81-year-old female who comes complaining of progressive decrease in vision in the right eye more so than, or excuse me, in the left eye more so than the right. And she correspondingly has reduced visual acuity to match that chief complaint. So her vision in the left eye is severely reduced to 2100, and the vision in the right eye is reduced to about 2040. And first, just looking at her color fundus photographs in both eyes, really looking at areas of geographic atrophy, which in this case are quite obvious. I want to make sure we all know what that looks like. So we have these well-demarcated regions of hypopigmentation or RPE loss, typically revealing the large underlying choroidal blood vessels as well. And with regards to her OCT findings, I want to start off talking about the worst eye first here, which is the left eye. And so I'd like to ask the panel here, do you think, how would you describe this geographic atrophy? Is it center involved or non-center involved?
Dr.
Yes,
Haynes, what do you think?
that left eye would be center involved.
Yeah, absolutely. I think the acuity matches that. It's kind of cluing you into that already. And really severe photoreceptor and RPE loss involving the center of the fovea. And then we have this pretty uniform choroidal hypertransmission, again, in the center of the fovea. So it kind of makes sense with regards to our visual acuity for this particular case. And so let's now move on and talk about the less affected right eye. And I first want to ask you guys about the geographic atrophy, how you're going to describe it, and then why is that important? How does that come into play in your clinical thinking? And so would you describe this as foveal or extrafoveal? How about you, Jessica?
So for this patient, based off the photo and the OCT, it does not appear to be affecting the fovea. Multimodal imaging can sometimes be more helpful to see things in different ways. So looking at it with fundus autofluorescence as well. But this is a fairly large lesion, even though it's not affecting the subfoveal space, it's encircling the fovea and appears to have multiple foci of disease.
I love it. Yeah, I agree with you. I think it's probably extrafoveal and multifocal. And, how does this come into consideration in a clinical setting?
Well, when you think about multifocality is an indicator of progression. And actually, in fact, in complement trials, that was one of the indications for enrollment was you could actually have a smaller lesion size, but if it was multifocal, it allowed you the opportunity to get into a trial, just given the fact that it's more likely to progress.
Yeah, I think that's a great point. And the fact that it's bilateral as well, right, puts it at a higher progression rate compared to, let's say, if it was unilateral or something like that. So just based on the presentation thus far, we know that the progression rate for this eye is probably going to be faster than compared to perhaps other phenotypes of geographic atrophy. There's a lot of value in fundus autofluorescence, also in helping you gauge the prognosis. Is it going to enlarge or not? Unfortunately, don't have the fundus autofluorescence to share in this particular case, but I think Jess, you nailed it. That would be of a whole lot of value should we have had that in this particular setting. So I want to take a moment and point out some of the specific OCT features that are associated with early geographic atrophy formation, many of which are high-risk biomarkers for future geographic atrophy development or expansion. And the first one are hyporeflective wedges. And so these are dark triangles where the base rests on the surface of the RPE. They usually border areas of geographic atrophy. The second being subsidence or sinking of the outer plexiform layer, where it's sort of V-shaped and dropping down into that area of photoreceptor loss. And then subretinal drusenoid deposits or reticular pseudodrusen, Jess already very nicely pointed out, is a risk factor for geographic atrophy and advanced AMD in general. And then we also have one unique one here, which is a hyperreflective crystalline deposit or sub-RPE plaques, they're sometimes referred to as. And so this is a hyperreflective linear line, usually in the subretinal or sub-RPE space, corresponds to refractile shiny drusen when you look at it with ophthalmoscopy, also a risk factor for geographic atrophy. I'm going to digress from the case for just a moment to really point out and bring home what are the early features of geographic atrophy, which in a clinical setting to me, right, means that this is a patient I should watch very closely for development of full-blown GA that I would want to refer out for consideration of complement inhibition therapy. So we had talked about these hyporeflective wedges, usually have a pair on either side of geographic atrophy early lesions. And then we talked about sinking or subsidence of the outer plaxiform layer that tends to form this gull wing, like seagull type of configuration. Let's now take a look back at what this patient's left eye looked like when we first saw her 2.5 years ago. And so her very first examination at baseline over here is on the left, and then her most recent examination over here on the right. See, even early on in the course of the disease for the left eye, she started out central, right? Versus the right eye is still going extrafoveal. So I think this case really brings home the diverse, unique nature of geographic atrophy. Even in the same individual, each eye can be affected very differently, have different patterns and different sort of progression of rates associated with that. Do you think, based on the color fundus photography here, that there has been progression over time in this eye?
Yes, this patient definitely looks like they have gotten worse from baseline over the last 2.5 years. One interesting thought on treating patients like this who are already center involving is to see that even though the visual acuity may not change as they progress, the size of that scotoma increases over time. So is there some value, and Yasha may speak to this, in still treating these patients for trying to control the size of that scotoma?
Yeah, Dr. Haynes, that's a great question. I mean, these patients were actually enrolled in the Derby and Oaks clinical study. I think it's a tough call, right? There's only so much money in the pot, if you will, of CMS dollars, and so I would argue probably, when we take these patients, we probably want to go and look and say, well, what's going on with the other eye, and can we get more bang for their buck? But you're absolutely right. This is somebody where, yes, they're count fingers at baseline and they're count fingers 2.5 years later. But these are probably patients that are still relying very, very heavily on their right eye for functionality.
Yeah, I agree with that. My other question was, do you think the visual acuity has been changing over time? And I think, you spoke to that already, Yasha, which is it's been bad and stably bad, unfortunately, because once it becomes center involved, the vision declines. And here's now the right eye. And again, we're looking at a snapshot in time of 2.5 years. So we're going from baseline over to this 2.5 year follow-up now for the left eye. And just based on the color fundus photography, again, I want to ask you guys, do you think that geographic atrophy has enlarged?
This highlights so many of the shortcomings of fundus photos, right? Because if you look at this, you could sort of say, well, maybe it has, but it's a game of real estate, right? And you can't tell what's happening at the fovea. And so sometimes just using, you had some OCT images on the cross-sectional image. Well, the near infrared reflectance that accompanies the OCT image can provide you a lot of clarity in terms of understanding the progression of geographic atrophy.
Completely agree with you. And I think, real take home point here is that color fundus photography alone is probably not the best way to monitor progression of geographic atrophy or initially detect it, right? Multimodal imaging, OCT, fundus autofluorescence is going to add a lot of value in this case. I do think, you can kind of visualize these larger choroidal vessels more so than you could in the past. So it's sort of suggestive of enlargement, but there's probably a better way that we could look at this. Do you think that visual acuity has changed over time throughout this 2.5 year time span?
It's possible that it hasn't. The patient may still have the same visual acuity they started with. However, again, their visual function may be continuing to decline.
Agreed. Yes, she was like 20/40 pretty much throughout all of these follow-ups here. But again, complaining to us that the vision has been getting worse and she's having problems with her activities of daily living. So you cannot use visual acuity as a way to monitor progression of geographic atrophy, right? The only time visual acuity is going to change is when it goes from extrafoveal, boom, to foveal, like that case you shared, Jess, which was excellent. So here's a better way, I think, to look at progression of geographic atrophy over time. So this is in-FOS OCT analysis, and specifically, we're looking at the Zeiss advanced RPE analysis, and this is the sub-RPE slab sort of preset of that. So what we're looking at is a slab of 2D data just underneath the RPE, and we're mapping out areas of choroidal hypertransmission. Remember these bright areas coming down through the choroid? We're seeing them now in a 2D format on this in-FOS OCT image. And what's really nice about this advanced RPE analysis is that just looking, I mean, you can tell it's enlarged over the course of just 1 year of these 2 OCTs, but then we also get quantitative data that we don't get with color fundus photography or fundus autofluorescence. And so this quantitative data tells us, yes, there has been a trend in geographic atrophy enlargement over time. There's also a trend with the orange line here that it has been getting closer and closer to the center of the fovea and threatening that good vision, right? So, I'd love to open this up for discussion now and ask, particularly Yasha, is this a patient that you would treat, and which eye would you treat, or would you treat both?
I think the RP analysis maps are just so helpful in terms of understanding in a more quantitative function, sort of a change of area over time and then progression to the fovea. Because as you had pointed out, it's really time to fovea is really what we're looking at in terms of when somebody's going to sort of precipitously fall in terms of their visual acuity. Now, I think in the right eye, certainly this is a patient who we would really start to have that conversation about complement inhibition. This is somebody who's progressed over time. They've had considerable vision loss in the other eye. And so I think this is certainly somebody who I'd want to treat. I'd probably start with treatment in the other eye, just given the side effects that we had talked about previously, and then very much consider treatment in the right eye.
I think that's a excellent plan and management moving forward. How would you discuss with the patient in terms of education, like what to expect with treatment?
That's a hard part. And I think a lot of retina specialists are struggling with this concept. And I think maybe a couple of weeks ago, when the safety profile seemed a little bit safer, we probably were just going to say, well, this is going to slow your area of geographic atrophy. And therefore, over time, as time goes on, you will benefit from this. But, in medicine, we talk about frequently a number needed to treat and a number needed to harm. And in the Derby and Oak studies, we don't really have a clear number needed to treat. But actually in Gather 2 and Gather 1, which is the studies that FDA approval studies for Avastin capsid pegol, we do have a post hoc analysis, and they looked at time to 15 letter vision loss. And in those who were receiving the drug, 10 people lost vision, and those who were not receiving the drug, 26 people were not, which basically gives you a number needed to treat of about 1 in 16. So that is, you have to basically treat, if you think about it as a population, you have to treat about 16 patients for one patient to have a benefit of not losing 15 letters. So retina specialists and kind of our entire community has to sort of think about this as we're sort of taking an approach where we think about geographic atrophy at a population-based level, where maybe not everybody is going to benefit from this, but as a whole, you're more likely to benefit from this through this data.
Yeah, I think patient education is going to be so important with these therapies because the vision is going to continue to decline as they're receiving treatment. They're going to be like, well, I'm going through the burden of these injections every month or every other month, et cetera. Intravitreal injections it is versus some more simplistic form of therapy. And yet their vision is still declining when they're expecting improvement. And so I think we need to be very clear in terms of setting realistic expectations as to what to expect with regards to treatment outcomes. Jess, any last minute thoughts on this case?
I do love the sub-RPE slabs showing these sub-RPE illuminations. It is so nice to be able to see this in that on-FOS way. And I think for patients, that's also extremely valuable. Yes. Because again, you're trying to show a patient why it's important to be treated, even though their vision is not going to get better, even though they may continue to progress, because you can show them without treatment, this is definitely changing over time. Here are your images. And with treatment, the goal is to slow this down.
Yeah, I love showing patients images, especially their own images, if at all possible, when I'm doing patient education. And this is really like my go-to, where I can show them, oh yeah, you have geographic atrophy, it's getting worse over time. And hopefully in the future, I mean, I can show that some patients, the trend line's kind of, getting less steep, and they're actually improving from treatment as well. I think that'll be valuable also.
Yes, having those trend lines is that's a very neat thing, a very applicable thing to see how that could potentially be affected by treatment.
I think that's it, right? Like, and that's probably going to be the only sign that we have to go and show patients. So really having quantitative data where we're sort of so accustomed to qualitative approaches in OCT is going to be really critical to try and get patients to buy into treatment for geographic atrophy.
Yeah, I completely agree. Well, thank you guys so much for your insights on this case.
Thank you, Carolyn. That's an excellent case.
And just beautiful images.